Welcome, everybody. We're going to go ahead and get started. Firstly, thank you so much for coming to attend our talk. We're going to be presenting on psychiatric and neurodevelopmental comorbidities and XXY. And just to preface, the term comorbidity is just a fancy way of saying a co-occurring diagnosis. So I'm Srishti Rau. I'm a pediatric neuropsychologist. I work at Children's National Health System in DC, and I'm also working on this study through the Developmental Neurogenomics unit at NIMH.
And I'm Erin Torres, and I'm a psychiatric nurse practitioner, and I also work with Dr. Rau on the Developmental Neurogenomics unit at the National Institutes of Health in Bethesda, Maryland. And I just wanted to kind of give a disclaimer before we started. We might use various terms to refer to XXY syndrome, but we're saying XXY. So we say KS, Klinefelter's 47XXY, we mean XXY. And we'd also like to ask if people save their questions till the end, and we're going to make time to leave for questions and answers. And we know that some people are also asking questions virtually, so we'll try to get some of those questions answered before we answer the questions in the audience. Okay, so I just want to go over our objectives. So we will briefly review what previous research has demonstrated regarding rates of neurodevelopmental and psychiatric diagnoses in XXY. We're going to provide preliminary results from our sample of individuals with XXY in order to discuss the variability and symptomatology among individuals with XXY and to underscore the need for multidisciplinary and comprehensive evaluations and treatment. We are also going to briefly provide guidance regarding key professionals and types of services that may support areas of struggle. And then quickly, sex chromosome aneuploidies. So typically there are 22 pairs of chromosomes plus 1 pair of sex chromosomes. And in 47XXY, males have an extra X chromosome, as you can see there on the bottom right-hand corner. And again, XXY is also known as Klinefelter Syndrome. It occurs in between 1 in 500 and 1 in 1,000 live male births. And I've been reading it's usually about 1 in 600, 650 male births. Many men with XXY go undiagnosed, and of course this is changing with prenatal testing, but I've been reading only about 25% of males are diagnosed with XXY, so it leaves a large majority of males that we are not able to research because they don't know that they have the syndrome. And then just some physical features. It can include tall stature, smaller testes, and difficulty with fertility. It is actually the most common genetic cause of male infertility.
We're going to spend a lot of time talking about areas of struggle or challenges that boys and young men with XXY often face. So we want to start this out by emphasizing the fact that, as Dr. Rosnahan mentioned in his talk, the number one rule really is variability, in that all individuals with XXY have their own strengths and weaknesses. There is no one set outcome. And the types of things that we're going to be describing are some commonly observed challenges, but that, again, each person is their own individual and has their own strengths and weaknesses. So there's an increased risk of impairments with language processing in boys and young men with XXY. In fact, compromised language development is characteristic of boys with XXY, with 70 to 80% of children with XXY having language difficulties that are typically present as early as 24 months. Executive functioning is also often compromised in individuals with XXY. And you probably heard the term executive functioning a lot today. I wanted to just briefly describe what exactly it's referring to. So executive functioning is this umbrella term that's used to describe a number of processes. It includes things like being able to sustain your attention to a task or a problem-solving initiative. It also includes the ability to hold information in mind mentally in order to problem solve or execute a goal, what's also known as working memory. It includes things like impulse control, being able to respond flexibly. So you start solving a problem, it's not going the way you expect, you stop, switch gears, and try a different problem solving strategy. Flexibility can also impact sort of individuals' ability to respond to transitions or how they react to situations that aren't going as they would expect them to. Organization and planning are also aspects of executive functioning, so sort of being able to pause and generate a plan before just impulsively launching into a problem. There we go. Social cognition is another area that can sometimes be compromised in individuals with XXY. Social cognition refers to being able to accurately interpret others' thoughts and feelings and behaviors. Another term for it that's sometimes used is called theory of mind. I'm going to talk a little bit more about this on a subsequent slide where I talk about rates of autism spectrum disorder, which are higher in boys with XXY. And finally, emotion regulation also tends to be compromised, and this can include things like handling disappointment, reactions to limit setting by parents that can often result in an increased emotional reactivity than expected. Oftentimes, challenges across these different domains can contribute to elevated rates of different neurodevelopmental and psychiatric diagnoses. So for example, more compromised language development has directly been associated with higher levels of autism spectrum disorder, or rather autism-related symptomatology in children and adolescents. Before we go into talking about different types of rates of diagnoses in the XXY cohort that we've recruited, we want to briefly review the literature to tell you about what's been found so far in research. All right. So in regards to IQ, which refers to sort of cognitive reasoning, intellectual reasoning abilities, generally, individuals with XXY tend to have IQs that are comparable to similar age peers without XXY. They sort of fall in the average to lower end of the average range. Typically, intellectual disability, or what used to be called mental retardation, is not a commonly co-occurring diagnosis for individuals with XXY. Oftentimes, in some studies, the literature has shown that some of the compromised language abilities that I was referring to earlier can be related to relatively weaker verbal reasoning abilities relative to visual spatial reasoning abilities. This has, however, more often been found in younger cohorts in research, and when adults with XXY have been examined, there's that discrepancy tends to be diminished. So ADHD is a diagnosis that can include symptoms of inattention. So that includes things like distractibility, difficulty focusing on a task for a long time unless it's fun, problems keeping information in mind, so working memory, problems organizing information and materials, and it can also include symptoms of hyperactivity and impulsivity. So for example, being constantly on the go, impulsive, talking excessively, difficulty waiting until their turn. There's 3 presentations of ADHD. Individuals can be diagnosed with the predominantly inattentive presentation, meaning that they're showing more symptoms of the inattentive symptoms. There's a predominantly hyperactive impulsive subtype, indicating they're showing predominantly hyperactive impulsive symptoms. And then there's the combined presentation, which is a combination of both domains of symptoms. Youth with Klinefelters demonstrate a higher prevalence of attention disorder diagnosis relative to the worldwide prevalence of 7.2%. So as you can see, compared to 7.2, individuals with Klinefelters are showing rates of about 36% amongst children and young adults with Klinefelters. And of those with ADHD, the predominant presentation tends to be the inattentive presentation. So again, the one where there tends to be more symptoms of inattention rather than those of hyperactivity and impulsivity. When ADHD is examined in adults with Klinefelters, it's found that there continue to be elevated rates, and adult men with Klinefelters are 5.6 times more likely to have been diagnosed with ADHD relative to XY men. And symptoms of ADHD, as well as related executive function, impact academic achievement as well as occupational attainment throughout the lifespan. All right. So I'm going to now go into talking about, apologies, I've gotten my papers all mixed up here. All right, here we go. So I want to just briefly describe what I'm referring to when I say learning disorder. So a learning disability is a neurological difference that affects how a person receives and processes information. People with learning disabilities can have trouble with reading, writing, math, and these struggles often contribute to academic achievement that's lower than expected given a child's intellectual ability and access to proper education. Between 8 and 10% of children under the age of 18 in the United States have some type of a learning disability. However, as you can see in this statistic, that rate is quite elevated in boys and men with XXY. So reading disability is, research has shown, ranges from 50 to 75% in boys with XXY. And while language-based LDs are most common, there's also a subset of boys with XXY that show kind of broader learning challenges that also encompass math difficulties. And not only does it impact their learning at one point in time, but what longitudinal research has shown is that the pace of acquiring these academic skills tends to be slower in boys and men with XXY, such that the gap between them and their neurotypical peers tends to widen as they get older. And in fact, a lot of these struggles can persist into adulthood, whereby about 70% of men with XXY tend to show some evidence of a reading disability. So autism spectrum disorder is characterized by difficulties in social communication and the presence of restricted and repetitive patterns of behaviors and interests. Individuals with autism may demonstrate difficulty developing and maintaining relationships with peers, struggle to understand social cues and use clues in their environment to sort of guide their behavior. And they can also have difficulty accurately interpreting others' thoughts and feelings or their intentions. So again, that social cognition theory of mind piece. They may also demonstrate repetitive behaviors, strong interest in certain topics or activities, and those can get in their way or in the way of their families. And these can include difficulty adjusting to changes in routines and differences in processing sensory information. The worldwide prevalence rate of autism is 0.6%, and in the literature, autism rates in males with KS vary depending on the measures that were used to assess the symptoms, but also the methodology that was used to assess the symptoms. So when studies use primarily parent reports, so something like the autism diagnostic interview or just screening measures that are like parent questionnaires, the rates tend to range from about 12 to 47%, with an average of about 25% being diagnosed with autism or meeting criteria for an autism diagnosis. However, when studies use a more comprehensive assessment, which includes things like interviewing the individual, ruling out other diagnoses that could be contributing to symptoms, having a team consensus, reviewing DSM-5 criteria, those rates tend to be lower, ranging from 5 to 10%. And in studies that have looked at adults, adult men with XXY are diagnosed with autism 6.2 times more often compared to those with XY.
And I'm going to speak briefly on mood and depression. So we have different subsets of mood disorders. I'm going to talk about major depressive disorder, which is kind of what people think about when they think about depression. It's when an individual is experiencing a lower sad mood and within the same 2-week period. They also have 5 or more symptoms, which would be loss of interest or lack of appetite or an increase in appetite, some kind of sleep disturbance. They might have suicidal ideations or specific plans or just kind of a suicidal ideation. They might have feelings of fatigue and worthlessness and trouble concentrating. And again, with this diagnosis, it has to be these symptoms in the same 2-week period. So sometimes somebody who has depression might not have every single symptom related, but they're also having symptoms and that's impairing their functioning for daily life. We also have dysthymia, which is kind of what I like to think of as the Eeyore of the group. They just kind of have a low mood pretty persistently. They're kind of around, but not necessarily as involved or not necessarily as euphoric as their peers might be. And then we have what's called disruptive mood dysregulation disorder, and this is characterized by recurrent temper outbursts, also with a sad or irritable mood most days, nearly every day. And this isn't just the temper tantrum that a child might have. These are temper tantrums that are occurring across multiple settings and that they're actually impairing the family's ability to even go out to the grocery store, his ability to go to school. As you can see here, many people suffer from depression, approximately 300 million people, and the lifetime prevalence of depression in adolescents ages 13 to 18 years old, the lifetime and 12-month prevalence was 11 and 7.5% respectively. And of course, when we look at the literature, the rates of depressive disorder and XXY vary. And again, as Srishti alluded to earlier, this is all dependent on the measures that they're using, whether or not it's a questionnaire base or if they're using strict DSM-5 criteria. And then we have anxiety. So we have different subsets of anxiety disorders. We have generalized anxiety disorder, and this is characterized by an excessive anxiety or worry about various topics occurring more days than not for at least 6 months. So these topics can be work, school performance, children, current events, and it's just something that's really impairing. The person finds it difficult to control their worry, and they often wish that they didn't worry as much as they do. The anxiety and worry are also associated with at least 3 or more of the following 6 symptoms, which are restless, fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. And it's to be noted that when you're assessing a child, they only need to have one of those symptoms to meet criteria for generalized anxiety disorder. Then there's social anxiety disorder. So of course, speaking in front of all of you guys has been causing me a lot of anxiety, but I am able to get up here and do it in front of you guys. But people with social anxiety disorder aren't able to do it, and it's not for lack of wanting or lack of trying, but it's just that the fear or anxiety that's associated with being in a social setting is too impairing. And sometimes with children who have social anxiety, 504 plans, IEPs can help with this because they can potentially do their presentations just one-on-one with their teachers. So it's not that they're getting a 0 on the assignment, they're able to still produce the assignment because it can be pretty intimidating to present in front of your peers. But the social anxiety is usually because the patient or the person is fearing that they're being scrutinized or that they'll do something and they'll be rejected. And this can really produce a lot of distress. We also have specific phobias, which is a persistent fear of a particular item or situation. So popular phobias are clowns, heights, claustrophobia, which is fear of enclosed spaces, arachnophobia, which many people have heard of because of the movie, which is fear of spiders, needles or holes. And of course, it's not just that you don't like them, because a lot of people don't like needles, but this is the persistent fear that really causes it a lot of anxiety and a lot of apprehension to actually have their blood drawn or whatever the case may be. And then I didn't list it here, but another common form of anxiety that I've seen is separation anxiety. And this is when the child has difficulty not being around their parents for fear of something happening to them that will cause them to not get back together again. And you can see this sometimes in refusal to go to school. And of course, we also have to rule out that that refusal is not due to some kind of learning disability that's causing them to have trouble in being bullied or bullying itself. And of course, the kids don't want to go. But sometimes just that intense fear that they're not going to be able to see their parents again, they don't want to go to school. This can also occur when parents are going to work, that they're having a lot of anxiety, temper tantrums, various symptoms because they're worried that something will happen to their parent and that they're not going to come back. And rates of anxiety disorder in XXY, again, range anywhere between 14 to 12%, depending on what measures that they're using to fit criteria for a diagnosis. And it's not within the scope of this presentation to comprehensively review all of the comorbid diagnoses in XXY, but we wanted to try to provide a brief overview of the ones that have been reported most frequently. However, these diagnoses can also occur in XXY: psychosis, bipolar disorder, obsessive compulsive disorder, OCD, or Tourette's, or a specific tic disorder, whether it's motor or vocal. Moreover, this is the research when we were looking through has kind of given us even more motivation for our study. We want to make sure that we have a larger sample, that we have more detailed multidisciplinary assessments using multiple modalities of assessment, such as questionnaires, performance-based testing, and interviews both with the parents or guardian and the patient, and we use gold standard assessments. And then, as you've probably seen today, this is the NIH, this is where we work, this is the clinical center. And most of our participants come in for a 2-day visit. We've occasionally shortened it or elongated it depending on what the participants need. But throughout the time that they're there with us, they'll go through a quick history and physical. We will get vital signs, and we also have labs. We do labs for research with the participant and their family members. And then depending on the variation that we're studying, we also do specific labs for that group. And they also come in, they see myself, and they go through a case-ads assessment, which I'll speak about later, and then they go through a comprehensive autism assessment with a group of psychologists using the ADOS and ADI. And at the end of it, we try to give all of our families a written report summarizing these findings from the psychological reports, the case-ads assessments, and any recommendations that we might have. And it's really been amazing to see how all of the families have come through and really dedicated themselves and really powered through the assessments. I know we ask a lot of you guys, and we've also gotten a lot of great feedback from the families, and we're incredibly thankful for all of you guys helping us work towards understanding the XXY variation. And again, before we get into our findings, it's really important to emphasize a couple of things up front. I'm sure you guys have heard today that there is the ascertainment bias. So the numbers you show or that you're going to see are the numbers that we're getting from individuals that have XXY that have gone through our study. And as I said earlier, there's a large percentage of males that don't know that they have XXY syndrome, so we're not able to get them in the study. And then also just kind of knowing that what we're seeing is a current thing. It's a snapshot in time, and assessments should be repeated because as time goes on and as interventions are introduced and as patients are maturing, things can change. And we all have our strengths and weaknesses, and we want to make sure that we are getting the correct diagnoses, the correct treatments to kind of help them do the best that they can.
So we're going to transition into talking about the XXY participants that we've seen so far. As we mentioned, recruitment for this X and Y variation is ongoing. So we've currently seen 60 individuals with XXY with an average age of about 17 years old, but they range from 7 years old all the way up to 25 years old. About 1/3 of our participants were diagnosed prenatally or at birth, and then 2/3 were diagnosed postnatally. And for those that were diagnosed postnatally, the mean age or the average age was about 10 and a half years old. As Erin alluded to, we collect a lot of information in our study, and it's just not within the scope of this presentation to be able to give you all of those results. We're primarily going to be focusing some of our data on the diagnostic status of the individuals we saw, as well as giving you some information from some of the parent report measures that we collected. So some of the data that we'll present today include parent report questionnaire data from the CBCL, or the Child Behavior Checklist, or the ABCL, which is the Adult Behavior Checklist, the SRS, which is a Social Responsiveness Scale, and the BRIEF, which is a parent report measure of executive functioning. The CBCL and ABCL provide information on social, emotional, and behavioral functioning, and the SRS provides information on social functioning. This slide here just is sort of a visual representation of the information and statistics that are on the previous slide. For those of you who are more visually inclined and tend to understand information better in charts. So the pie chart on the left is, again, just reflecting that 2/3 of our participants were diagnosed postnatally and 1/3 were diagnosed prenatally or at birth. And then the histogram on the right side is showing you the distribution of ages of the participants that we've seen. So towards the left end on the x-axis, if you're not able to see, it shows 5 years old, and towards the right, it shows 30 years old. And as is reflected here, our sample tended to be a little bit older, so we tended to have more individuals who were adolescent or at the later end of adolescence. So I'm going to start by describing the prevalence of ADHD in our sample. So almost 2/3 of the individuals in our sample met criteria for ADHD, and the majority of those that met criteria for the inattentive presentation, and that's reflected in this pie chart here, and that's also consistent with what the prior literature looking at ADHD and XXY has shown. So what about those that don't have a diagnosis? It means there's no problems, right? Not quite. Amongst those that did not meet full criteria for an ADHD diagnosis, parent reports still indicated that 12% of those individuals were having clinically significant challenges with attention regulation, and 1/5 of them were having clinically significant challenges with executive functioning. So we're going to kind of use this approach as we're showing all of the diagnostic results. So we'll kind of give you the diagnostic rates, but we also want to underscore the fact that just not meeting diagnostic criteria for a diagnosis does not mean that the individual is not having challenges with symptoms that are related to that diagnosis. So in terms of autism spectrum disorder, we completed a comprehensive assessment with the participants that came through, and these included gold standard measures. So we individually assessed the participants themselves using the Autism Diagnostic Observation Schedule, or ADOS. And this is sort of a conversational and play-based interview that varies depending on the person's age. So for the younger kids, there is more play involved, whereas for the older kids, it is just kind of more conversation and talking back and forth. And it really pulls for some of those symptoms of autism. So for example, I may say something to the individual like, I went on a really cool vacation. And the expectation is that they would ask me where I went or what I did. Whereas oftentimes individuals with autism may not pick up on that cue to follow up the interviewer's bid with a question. With parents, we also do the autism diagnostic interview, which is the ADI, and that asks very specifically about autism symptoms currently, but also during a very specific developmental period between 4 and 5 years old, when a lot of autism-related challenges manifest in young children. And so not only do we take these data, but then what we do is we meet as a multidisciplinary team to discuss, so are these challenges truly related to autism, or are they better explained by a different diagnosis, like for example, social anxiety, ADHD, language delay, et cetera, because we want to make sure that if we're going to be making an autism diagnosis, that it's truly an autism diagnosis and not due to something else. And we also review DSM-5 criteria as we're making these diagnostic decisions for autism. So 12 participants of the 60 that we saw had a prior diagnosis of autism when they came into our study, and following comprehensive assessment, 2 of them did not meet criteria for ASD, and 10 diagnoses were maintained. 80% of the sample came into our study without a prior diagnosis, and 8 were diagnosed for the first time. So if we kind of look at the total diagnostic rate for autism in our sample, it comes to about 30%. And I do want to qualify this because data collection is ongoing, so this rate can change. We may be going back and collecting some additional autism symptomatology data from some participants who have already been seen. So again, for even those amongst those where we did not make an autism diagnosis, parents were still reporting clinically significant challenges with social skills amongst 35% of those individuals, and half of the individuals that did not meet criteria for an autism diagnosis, the parents were indicating clinically significant challenges with executive functioning, which is often a skill that's compromised in individuals with autism spectrum disorder.
And the people that come through go through a case-adds assessment with myself, and it's the Schedule of Affective Disorders and Schizophrenia for School-Age Children. And it's an assessment completed with the parent or guardian and the client and his sibling as well. And it assesses current diagnoses and past diagnoses. So it starts with a history, and it consists of prenatal questions, medical history, developmental history. I also ask about educational history and whether or not they're getting any services, what kind of school environment they are in at the current time. And then we also have implemented an employment screen because we do see children or males up to 25. And so we're also tracking what kind of employment they're in, what do they find as kind of weaknesses in their employment, and what are they good at and what makes them a good employee. So the tool, the way that it goes is that I ask screening questions, as it will, for all of the diagnoses. So questions about depression, if they have a sad or depressed mood for a couple of days in a row, do they have it for the entire week? How long does that last? Are they having any suicidal thinking? For anxiety, is it that they're a little bit shy, but they're still able to go to school and they go to parties and they engage? Or is it they're so shy that they're not able to speak to anybody once they're there? And so we go through all of those screening questions for all of the disorders, and then depending on how those are scored, I might have to go into the supplement, and that's when you actually get the diagnosis for the DSM-5 criteria. And so here you can see that about 12% of our cohort met criteria for any kind of major depressive disorder or any kind of mood disorder. And of that, 3.3% met criteria for major depressive disorder or dysthymia, and about 5% met criteria for DMDD, which is the disruptive mood dysregulation disorder. And then, of course, you can see also that just because they didn't meet full criteria does not mean that they didn't have any difficulties. So about 30% of our sample per parent report showed clinically significant symptoms of this internalizing behaviors on the CBCL. And some of these internalizing behaviors can be sadness, crying, being fearful, preferring to be alone or isolating themselves, having nightmares, headaches, withdrawn. And then for anxiety, per the CASADS report, 20% met criteria for an anxiety disorder, and this is full criteria, and 12% of those met criteria for a generalized anxiety disorder, and about 7% met criteria for social anxiety. And then again, just because they didn't meet criteria does not mean that they didn't have any symptoms that were causing any kind of distress or impairment, and about 17% per parent report on the CBCL experienced internalizing symptoms. Yes.
So is that really 20 plus 11 plus 6? So you're talking about almost 40%?
No. So of the 20% that met criteria, the way that it was separated out was some met criteria for generalized and then some met criteria for social.
So this is just a bit of a summary slide that Dr. Rosnahan had also previewed in his presentation. It's just giving you an idea about what percentage of the participants that we saw met criteria for how many diagnoses. So about 43% did not meet criteria for any diagnosis. So as we continue to try to hammer home, that does not mean they were not having symptoms that were still contributing to impairment. 40% of the sample met criteria for at least one diagnosis, 12% met criteria for 2 diagnoses, and 5% met criteria for 3 diagnoses. There were not individuals in our sample that met criteria for more than 3 diagnoses. All right. So a number of previous presentations have indicated that individuals who are diagnosed prenatally tend to have better neurodevelopmental outcomes relative to those that are diagnosed postnatally. In fact, Dr. Rosnahan was also alluding to this in his presentation on the XYY cohort. And there's a couple of reasons for this. It may be that individuals that are diagnosed prenatally, parents may be more vigilant and looking out for some of the signs of developmental delay, or they may just seek out services proactively even though there aren't delays because they know that individuals with KS may have speech-language delays, for example. So what I'm trying to show in this slide here is basically the diagnostic rates of these different disorders, so autism, ADHD, depressive disorder, and anxiety disorder, in those that were diagnosed prenatally. So the prenatal diagnostic rates are on the left side of each graph, and the postnatal diagnostic rates are on the right side, and the bars in red represent the number that met diagnostic criteria for that kind of diagnosis, and the blue bars represent that the diagnosis was not present. To summarize, in our sample of 60, statistical analyses indicated that there were actually no significant differences in diagnostic rates for those that were prenatally diagnosed versus postnatally diagnosed, and that is somewhat different from what prior literature has shown. And we're not really sure right now. I think once we collect all of our data, we can rerun these analyses, perhaps with a larger sample size. Our results will change. But for now, it may have been that we didn't have the statistical power to show clinically significant differences between the postnatal and prenatal groups. All right. So now in terms of the things that we really want you to leave our presentation with is the fact that individuals with KS are at a greater risk for a number of neurodevelopmental and psychiatric diagnoses. However, even those that are not meeting full criteria are nonetheless they may have impairing symptoms related to a particular diagnosis. So in some, if you see something, say something. Don't just attribute a child's symptomatology to their genetic diagnoses, because they could also meet criteria for a comorbid neurodevelopmental or psychiatric diagnosis, and that diagnosis can open up doors to evidence-based interventions. So oftentimes insurance companies won't reimburse families for treatment unless there's a medical diagnosis present. And just because an individual has a genetic syndrome doesn't mean that symptoms can't improve. So if a child is provided an appropriate intervention, they can see changes in symptoms and symptom improvement. We focused our presentation on neurodevelopmental and psychiatric difficulties. However, there is a need to understand what is driving these, or the etiology of them, and how these relate to brain development and how brain development relates to genes. And that is what the rest of our research program is about. And some of this work was detailed by Dr. Rasnahan earlier today and will be available on the AXYS website. Finally, we want to sort of describe to you what are some helpful supports that are available to families for individuals of parents and families of individuals with Klinefelters. And I want to emphasize that what just happened here? All right, thank you. So the types of supports that parents and family members should seek out are going to vary depending on the individual child or young adult, but also the developmental stage that they're in, as well as their individual strengths and weaknesses. So at younger ages, it may be more appropriate to seek out speech-language services, ABA services, social skills therapy, and as children transition into school, getting academic interventions through something like an IEP or a 504 plan, psychotherapy to address some of the mood and social difficulties that can be comorbid with individuals with KS, psychiatry and endocrinology to potentially see if medication management can be helpful in ameliorating some of those symptoms. And finally, a big area that is an area of need for individuals with KS is transition support. So how do we support transition to adulthood? I found the AXYS website has some excellent resources in this regard, but there's also statewide agencies. So for example, in Maryland, the Department of Rehabilitation Services has a pre-employment training program, offers supported employment services that families can leverage. And I would encourage families to seek these out if you have someone who is about to transition to adulthood, or is maybe that's several years down the road, but you could seek these out and put your name on wait lists because you know there's going to be wait lists for everything.
And then these are the names of our team. So any of you that might have come already, you probably met Cassidy or Jay, and now we have new members of our team, Kathleen, Ethan, and Alyssa, and then Dr. Rosnahan, Jonathan, and myself, Francois. And then we have other members. The ones in gold are the members of the children's team. So Dr. Rau, Dr. Miller, and Dr. Kenworthy, they're our children's collaborators, and they also have 2 more people that will be coming in September. But we really like to thank all of you guys for participating in our study and helping us do the research. Without you guys, it would not be possible. We would also like to thank AXYS because they are helping a lot with the recruitment as well. And we really want to help you guys understand and continue to disseminate the research to all of you guys.
So if you're interested in learning more about the study or joining the study, I'm going to have Jonathan stand up and give a little wave because that's the person to get in touch with, and his email address is up here. And also just outside this room, our table is there with flyers that has information about the study. And there's also some families here who have participated in our study and who have expressed willingness to share their experiences from a family's perspective. So that's another really nice resource if you want to know kind of what it's like to go through it as a family member. You can seek out those families who have already gone through our study. So we have about 10 minutes left, so we would like to take some questions from the webcast and also from the audience. I'm not seeing any questions. Oh, here we go. So the question from a webcast is indicating, are you still considering the XXY study? There is so little data on this population. Go ahead.
So
Erin.
yes, we are currently recruiting for Klinefelter Syndrome, and then late to early next year we will be doing the trisomy X girls. But we are definitely going to be getting to the other aneuploidies, but I think it'll probably be another mid to late next year? Oh, okay. So soon. Much sooner than I thought. But yes, we will.
So this question is asking, is it possible to differentiate early onset dementia and severe learning disabilities that are memory related? Dementia can happen in children and 30-year-olds. So I'm a pediatric neuropsychologist. I know a lot less about dementia. I can say that I have not seen it occur in any of the children that I've worked with. However, if dementia, memory-related challenges are something that you're experiencing or something your family member is experiencing as an adult, I would strongly advise getting a neuropsychological evaluation with a provider in the community to rule out the presence of dementia versus a learning disability.
So the question is, has any research been done on separation anxiety in adult populations, such as day programs, independent living skills programs, et cetera, or in the context of community support worker? So honestly, I don't know the answer to that. I can imagine that separation anxiety can definitely occur into adulthood, but I'm not quite sure of the research available.
We'll take one more webcast question, then we can open it up to the audience here. Oh, looks like there's no more webcast questions, so we'll open up the questions to the audience that are here. Yes?
How do you teasing out the data for the autism spectrum disorder versus social pragmatic language disorder, because they changed the DSM-5 and because my son originally was on the autism spectrum and now has social pragmatic, and since you're correlating some of the symptoms and your results, how are you doing that?
Yeah, so we're kind of relying very strictly on DSM-5 criteria across the two. So for social pragmatic disorder, individuals that are diagnosed with that should not also be showing co-occurring restricted and repetitive behaviors, patterns of interests. So if we're seeing enough evidence of those, they definitely fall into the camp of, with co-occurring social communication difficulties, they would fall into the camp of autism spectrum disorder as opposed to social pragmatic disorder. And I would say that of the folks that have come through our study so far, I have not seen anybody who is showing only social communication impairments without the co-occurring RRBIs. Yes?
I don't have a question, but my family participated in the study, and I know we were a little bit anxious about it, so in case anybody else has the same anxiety about it, you're welcome to talk to me, and I can share what our experience was like. I will say probably our biggest concern was what it would be like for our second, at the time, 9-year-old boy, because it's pretty rigorous, and honestly, we got a 2-day
Thank you so much for sharing your experience and for being willing to speak with the other families. That's really nice to hear. Yes.
I'm just curious, I know you've looked at the XXY population and how often you find the autism occurs there, but have you gone backwards and looked at the high-functioning autism diagnosed children who haven't been given the microarray or the genetic test, and how often they're not diagnosed because they're stopped at that autism diagnosis? You know what I'm saying? Like,
Yeah.
they're
Right.
like, oh, that's diagnosis, but they don't find out that they
Also have co-occurring XXY?
Right.
Yeah, that's a really good question. So I'm not aware of the actual rates of what are the co-occurring XXY diagnoses in individuals with autism, but I will say that the American Academy of Pediatrics recommends genetic testing for individuals that are given a first-time autism diagnosis, and clinically in research, that is also something that I strongly put in all my reports as one of the first recommendations, that if you're getting an autism diagnosis for the first time and have not been
I read that, and I was strongly discouraged from taking my child to genetics after getting an autism diagnosis. So I wonder how many other families stop there because they're not getting that testing that there should be, even if it's recommended.
So you said that when your son was given an autism diagnosis, you were hesitant to get the follow-up genetic testing?
No, she was told not to.
The doctor told me,
Oh,
keep going. Why are you taking him to genetics?
okay.
I was the one saying, no, I'm
Yeah.
not.
That's,
That happens.
okay. That's alarming to hear, because that's not what pediatricians should be recommending for families.
Well, I went to a psychiatrist or a neuropsychologist.
Okay,
Pediatrician.
okay,
Still, I've heard that from many other
okay.
families, that they're discouraged from going forward.
Yeah. Well, thank you for that feedback. That's helpful to know. Other questions? Yes.
So is there any evidence about, how evidence-based treatments work in a general autism population versus autism that's associated with XXY?
That's a really good question. I don't know the research evidence for autism specifically in XXY, and I know there was someone who had talked about developing sort of ABA strategies specific to XXY, and I imagine that that was you. There you go.
Well, because I've never spoken to people about ABA, some other parents, and
Uh-huh.
about their frustration about not working in the like parents and family. And
Yeah.
Find a good tech and BCBA that's really great tools to deal with it.
so sort of the general rule might be doesn't think.
Well, I would say that regardless of whether the child has co-occurring XXY or not, if you have a good ABA therapist, they should be tailoring the treatment to the child's specific strengths and weaknesses rather just opening up a manual and delivering a treatment based on that manual. And I'm hearing some families saying that that's not what ABA therapists do. And sometimes I will say that it can take some shopping around. So you may find an ABA therapist after waiting 6 months on a wait list and find that they're not actually tailoring the treatment. And so it may take some shopping around to get to a therapist that is willing to tailor the treatment to your child's specific strengths and weaknesses. So we have about 3 more minutes. Yes?
You studied your XXY children very thoroughly for psychiatric issues. In a control or non-genetic group, did you have comparable degree of study for depression and anxiety? As you look at this, I mean, you had a very high percentage of people with XXY, anxiety, depression, etc. But I wonder if the control groups had as thorough a study for these disorders.
So the data that we were providing about kind of general population rates, those were based on the literature, not the healthy volunteers that are coming through our study. Is that what you were referring to?
And the healthy volunteers that are in our study, we do screen them to make sure that they don't have any psychiatric illnesses that would exclude them from being our healthies. And then also when they come in, I go over briefly with the parents and themselves if they've had any depression, anxiety, any kind of therapy and that kind of thing. But we haven't studied healthy volunteers in our cohort as far as giving them a KSADS assessment or anything like that.
I think we do try to, as Srishti Rau was saying, we also carry out some assessments on the family members. And in instances where there's an unaffected symptom, that provides an opportunity for detailed
We have 1 more minute, so we can take 1 more question. Yes.
When you look further into the postnatal versus prenatal data, will you be factoring into your review the socioeconomic levels of the prenatal group versus the postnatal group? Because I'm just asking because in support groups there are often questions whether, by the expecting parents, whether they can deal with the issues of having an XXY variation. And it may be theoretically that those who decided not to terminate think that they have the resources and ability to actually manage.
So that is a really good point. I believe we are collecting data on family socioeconomic status, and I think once we get to a higher kind of sample size, it could actually probably be feasible to look at the prenatal versus postnatal question and also factoring in socioeconomic status. So you raise a really good point, and I think we can definitely incorporate that into our analyses. So thank you so much for your participation and for being here and for the great questions and for the opportunity for us to present. Thank you.